Okay. Hello, everyone. We're going to be covering the application of manual and mechanical traction. It's going to be presented by myself, Armando, Emily, Mike, and Randy. So traction is the application of force. The goal is to open up the intervertebral space. We're going to reduce the pressure on the disc, the spinal nerve roots. We are trying to open up the facet joints, and we want to elongate soft tissue. The principles of traction are very simple. All of the force that we're going to apply to the patient, the sum of it needs to, the force needs to overcome the sum of the resistance of the weight of the body part, the tension in the surrounding soft tissues, the friction between the patient and the table, and the force of gravity. All of those combined. Characteristics of traction. So it can be administered by gravity. So we're going to use weights, or we're going to use our body weight. It can be applied by a machine, the clinician itself, or the body position of the patient. The mechanical force that's applied, it can either be continuous or intermittent, and it can occur in one plane or multiple planes.
Right,
Next,
so
we're going to cover the
types of
traction.
Sorry, go for it.
First off, we have continuous. So traction is going to be constant, and it can be applied for an extended amount of time. So we're thinking hours or even days. It's going to be delivered using a mechanical mean. So think weights or pulleys or some type of device. And it's going to be a very low load. And we're just trying to accomplish soft tissue elongation. Next, we have sustained. So this is going to be constant traction that's applied for less than 45 minutes. Again, going to be used by mechanical means. So think motorized units, weights and pulleys, and it's going to be a higher load than continuous traction. And the goal of it is to separate the bony structures. Next, we have intermittent traction. So this is going to be alternating between tension and no tension. And it's going to be delivered anywhere between 50 and 120 seconds. We're going to follow that up with an interval of decreased or no tension. It can be delivered using a motorized unit or manual techniques. And we're going to be delivering this at a very relatively high load. The goal is to stretch the soft tissue and separate the vertebra. Next, we have positional traction. So this is going to be traction that's applied to the patient's spine. And we're going to be using their posture or gravity to accomplish this. So the goal is to stretch the soft tissue and the effects that it has on the pressure of the bony surfaces. Next, we have manual traction. So this is sustained or intermittent, and manual means that it's applied by us, the clinician. Next, we have auto traction. So this is a mechanical traction where the patient controls how much tension that's being applied to their own body. And next, I'm going to hand it off to Mike. Mike's going to unmute first.
Thanks, pal. Okay, so first thing we're going to be talking about, angle of pull. So the angle of traction relative to the long axis of the vertebral column. In neutral, that's going to be in the transverse plane. In flexion extension, that's going to be in our frontal plane. Our C-spine facets are angled anteriorly. So then when we put them into flexion, that joint space is going to open up, and then space will increase. And then in our lumbar facets, they're angled posteriorly. So when we go into lumbar extension, that is what's going to open up the space and then increase in between the facets. And then we also have our unilateral angle of pull when we're going to be favoring one side or the other in the sagittal plane. This is going to be beneficial for our patients with muscle spasms or adhesions. and also going to be useful for facet joint pathologies or other nerve root impingements. So the important thing, we've already kind of checked up upon it, is tension. We're trying to overcome the amount of friction and the amount of body weight and the resistance from the other soft tissues. And we're going to be using the least amount of tension needed in order to relieve symptoms. As we increase our intensity of tension, we want to decrease our duration. So if we're going to be holding at a very high intensity, we want to do that for a short period of time. To whereas if we're going to be holding for a lower intensity, we can elongate that out for up to 120 seconds. Something important to remember is if we have too much force, that could end up creating muscle guarding, and then you'll prevent your patient from relaxing, which then we're not going to be able to open up any of the space in the vertebral column. Something to notice is that if we're doing too much traction and we separate our vertebral disc too much and we get too much nutrients flowing into that disc, we have the risk of overhydrating the disc and then leading us to an increased possible chance of rupture. Just something to be wary of, so that way we're not overdoing our traction. So the first pathology, you could say, that traction can be useful for is going to be degenerative disc disease, along with nerve root impingement. Obviously, degenerative disc is when the bone mass in the vertebral column decreases, which then decreases the space in between our vertebral joints. And the rubbing on those bones can then create bone spurs or osteophyte formation. And so to try and relieve that and to try and open up that space again for us, in cervical pathologies like this, we want to have them in flexion. If it's lumbar or if it's in both bilateral, we're going to have them in neutral position. And then if it's unilateral, we want them to be neutral with their spine still flexed to the opposite side, so that way we can focus on one side or the other. And this is going to be a sustained traction method. Here we have some other uses, or the main uses for cervical and lumbar traction. Obviously, we're going to apply our force. The muscle is going to elongate. This is going to increase our posture, which is going to decrease our muscle spasm. And then other main points that we're going to have is going to be tissue repair, reduced inflammation, and decreased pain. And this is going to be because of the elongation of the vertebral bodies, the flexion and extension, the different positions that we're putting them in, so on and so forth. Another pathology we're going to be looking at is disc protrusions. So obviously, if the nucleus is pushing out of the disc or out of the vertebral column, perhaps, we can use traction to try and reduce that force. This is going to be more beneficial in acute lesions compared to chronic lesions. In the acute phase, traction is going to be more successful at reducing that type of pain or those symptoms. Patients that experience pain during flexion, that's going to be caused by the nucleus being pushed posteriorly onto the nerve root, creating those signs and symptoms. So in the case of a disc protrusion, though, we're going to be doing it in whatever angle doesn't produce symptoms, whether that's extension, flexion, or in neutral. And this is going to be intermittent traction, where we're going to be holding for periods of time, then relaxing, and then continuing again, repeating that cycle. Another one we have, facet joint pathologies. When our facets are banging on each other, there's no space in between them. That can be irritating to people. And same type of idea here, where we're just trying to reduce the space and everything. But it will require twice the amount of tension to elongate the lumbar spine compared to the cervical spine. So you don't have to be trying as hard when you're pulling traction on the head or the neck as you would on the legs. And the reduced loading of these facets obviously is going to help to decrease inflammation in the area. And we're going to be looking at cervical traction in flexion and lumbar traction and extension. Once again, we're going with intermittent traction, holding for a period of time, relaxing for a period of time, and then holding again. Did this Okay, and then finally, so just other benefits, quick to note. Traction has had small benefits leading to improved circulation, increased metabolism in the spinal area, and then enhanced nutrition of those structures. So we're just increasing the nutrients in the disc itself and the areas surrounding it, decreasing the inflammation, promoting the healing.
Okay, so the next two parts we're going to be talking about is cervical traction and lumbar traction. So cervical traction, the instrumentation that is used for it is either like a motorized unit, which can be used to administer intermittent or sustained traction. Intermittent traction may be delivered manually, so with body weight, or sustained traction can also be administered through a weight and pulley system or a pneumatic device, which you can see at the top. The top image is the one that would be used for intermittent traction or sustained. And then for mechanical traction, it could also be applied via harness affixed to the skull. And then there's two types of harnesses, which is the mandibular occipital harness or the occipital harness, which the mandibular occipital harness is the one on the picture on the bottom, and then the occipital harness would be the one in the middle of the two other pictures. The only thing with the mandibular occipital harness that you have to worry about is TMJ pathologies. If the patient has experienced any problems with that in the past, you wouldn't want to use that type of harness because it might cause irritation for them. And then some of the parameters would be patient position. So they're seated, where the traction must first overcome the force of gravity before the therapeutic forces are placed on the cervical structures, or more tension is required to separate the vertebrae when the patient is seated than when the patient is horizontal. And then supine position, cervical muscles are able to relax because they're not having to support the weight of the head. And also a lower amount of tension is required to separate the vertebrae and obtain therapeutic effects. So the angle of pull for cervical traction, to open the intervertebral space, you have to place the cervical spine in approximately 25 to 30 degrees of flexion. This position straightens the normal cervical lordotic curvature, opening the posterior articulations, also widening the intervertebral foramen and stretching the posterior soft tissues. To separate the facet joint surfaces, the traction must be administered in at least 15 degrees of flexion. Also, when the patient is being treated in the seated position, vertebral separation is significantly increased when the patient is seated in the anterior lean position, increasing the angle of pull. The anterior portions of the intervertebral discs are compressed, and the posterior portion elongates when the neck is placed in flexion. And then also, when the cervical spine is placed in extension, the opposite effects would occur for the patient. And then tension, when the patient is placed supine, vertebral separation begins when tension is equal to about 7% of the patient's body weight when applied. The upper vertebrae, so C1 and C2, require much less force to separate than the lower cervical spine would because of the weight of the structures and the associated soft tissues. Also, the least amount of force necessary to produce the desired effect should be used with cervical traction. Um, and then significant increase in the opening of the intervertebral foramen between 5 kilograms and 10 kilograms. And then when you try to increase the force to 15 kilograms, there's not really a benefit added. Um, Excessive force can also lead to residual lumbar nerve root impingement and subsequent pain. So during the treatment, you just want to make sure that the patient isn't feeling any type of sensations in the cervical, thoracic, or lumbar spine and the extremities, because this can cause future um, problems for the patient along with what they already are suffering from. So pain for cervical traction can be reduced by decreasing the amount of mechanical pressure placed on the cervical nerve roots. Intermittent traction would improve blood flow and decrease myofascial adhesions. The same rhythm would also stimulate joint and muscular sensory nerves and inhibit the transmission of pain through the gate mechanism. Cervical traction would also decrease the radicular symptoms associated with cervical nerve root impingement, which is basically the primary goal of cervical traction. And it should also be sustained, or it could also be sustained through the provided time necessary for reabsorption of the nucleus pulposus if the patient is suffering from a disc lesion, which kind of talks about what Mike was saying about too much traction can kind of be a problem if you're not focusing or paying attention to like the cues the patient is giving you. And then there's going to be a list of the contraindications, precautions, and restrictions. But so contraindications would be acute injury, unstable spine, any diseases affecting the vertebrae, spinal cord, including cancer and meningitis, vertebral fractures, extruded disc fragmentation, spinal cord compression, a positive vertebral artery test, conditions in which vertebral flexion and or extension is contraindicated, osteoporosis, rheumatoid arthritis, and then also conditions that worsen after traction treatments or motion. And then for indications, which would be when you would want to use cervical traction, would be degenerative disc disease, herniated or protruding intervertebral disc, nerve root compression or radicular pain and associated muscle spasm, osteoarthritis or facet joint inflammation, a facet joint pathology, capsulitis of the vertebral joints, a pathology of the anterior or posterior longitudinal ligaments, and then also, like I said, cervical muscle spasm. And then the precautions, there's more precautions for cervical traction than there are for lumbar traction, but it should never be attempted in traumatic conditions that have not been evaluated to rule out a fracture or dislocation. The patient must be closely monitored throughout the treatment, and the treatment should be immediately discontinued if symptoms increase or if pain or paresthesia is experienced. Improper extension traction can result in a rupture of the cervical esophagus. Also, excessive duration under retraction weight can cause thrombosis of the internal jugular vein. Low tension should be used when hypermobility is present. Only sustained or continuous traction should be used when motion is contraindicated. And then the last precaution would be mandibular occipital harness. Like I said, should not be used if the patient is suffering from temporomandibular joint pathology.
So going over some of the evidence and the research that has come out within the past few years, a lot of studies have suggested that overall, when it comes to short-term relief with mechanical traction, it has proven to help with some pain, to help decrease pain, helps with any disabilities, helps improve some range of motion. And a lot of these studies you're going to find that they do have a bit of a higher statistical significance, but at the end of the day, there is lacking evidence for traction to be used clinically. There's still not really a lot of evidence that suggests long-term benefits of traction. And overall, the research is just still pretty inconsistent in terms of even just with short-term relief, because at the end of the day, when we think about how the physiology of, or when we think about the physiology behind traction, we're pulling apart areas to help relieve pressure. But as soon as that pressure, that traction is gone, that pressure is just going to increase again. If we think about it in terms of something like a muscle spasm, sure, that might be able to help reduce pain in that regard. But in terms of things like degenerative disc disease, or even facet joints, once that pressure comes back, symptoms are going to come back as well. So that's why there's just kind of like there's this insignificant amount of evidence to even suggest that traction itself does have any long-term benefits. And when it does come to short term, again, the research still is just pretty inconsistent across the board. So now we're just going to get into some lumbar traction. Yeah.
All right, perfect. Just really quick, I'm gonna give a quick intro on lumbar traction. Pretty much the process of distracting the individual's lumbar spine joints and kind of applying a tensile force through different methods or instrumentations. The most commonly applied instrumentation used is a motorized unit, which can help apply like a continuous and intermittent traction force, kind of more of a consistent force. Examples would include like the lumbar traction bell. Also along with that would be like a thoracic and lumbar harnesses, kind of separated just so that they can stabilize each compartment which they harness, and they can apply tensile force out there. Traction can also be applied via clinician or the patient to create an auto traction. And examples of these would be like hanging bars, where the patient could just hang off the bars, kind of apply their own traction. Utilizing the chairs, they can also use weights or bands, which are more clinician focused. Kind of gave. Oh, sorry, can you go back real quick? Just to explain the pictures. The first one on the top right would be an example of kind of like the motorized unit. Kind of does the splitting of the lumbar vertebrae, and the picture on the bottom right is kind of more kind of the auction portion, in which the clinician has a band they apply it around their glutes and put it onto the thighs of the patient, and kind of just apply like a inferior force back. All right, and then next slide. Some of the parameters included in lumbar traction include tension. So the increase of the tension is probably the primary difference between the lumbar and cervical traction, just because you don't really need a lot of tension for cervical traction, because just because of the structure and how little force is needed, as opposed to lumbar traction, you need a little more just because of the weight of the lumbar spine compared to cervical. So to create the lumbar separation, you would need half the force of the body weight to apply proper traction. So for example, if the lower extremity weighed 100 pounds, you'd probably need at least half of that, so 50 pounds, to provide some sort of traction onto the lumbar spine. And the ranges of these tensions can be variable, starting at 10% and go up to as much as 300% of the patient's body weight. Lastly, 90% of the vertebral separation occurs within the first 15 minutes. So it's kind of an important key there to note. Next slide. Also, positioning is a key parameter in providing effective lumbar traction. Patients can either be in a prone position or a supine, and this is highly dependent on the patient's comfort and spinal structure. Prone position usually utilized when the patient experiences discomfort in in the supine and the flex position. So an example of a pathology in which we put the patient in a prone position would be like a posterior disc protrusion or herniation. So in that case, you'd want to put them in prone as opposed to supine. However, and so there's also supine positioning, which helps increase lumbar flexion of the spine greater than prone, just because of the amount of hip flexion that you can get as compared to the prone position. So here I've listed some hip flexion degrees, which would increase the laxity of certain vertebrae. So hip flexion in 45 to 60 degrees can help increase L5-S1 laxity. Hip flexion with 60 to 75 degrees can help increase L4, L5 laxity. And lastly, hip flexion to 75 to 90 degrees can help increase L3 to L4 laxity. So just kind of some key numbers there. All right, perfect. And then so third parameter, optimal position and angle of pull is very important in determining effective lumbar traction. And it's kind of determined through a process of trial and error. Positioning, again, is based on pathology. So like I said previously, someone with a posterior disc herniation is more likely to go in a prone position. And then for nerve root impingements, you can put them in supine position. But overall, supine position is the best practice if patient has no pain and discomfort in it. As for unilateral positions, or sorry, pathologies, best practices would be to rotate affected side up and then apply a bolster and pillow underneath the affected area. That way it's not put under some tension and pressure and eliminates pain. So perfect. So with lumbar traction, it helps decrease a number of issues, such as lumbar lordosis, increasing disc height and stretching of the lumbar muscles. It can be effective in reducing muscle spasms caused by nerve root impingements, just by the mobility that it creates from the traction. And it can also help with lumbar spine joint fluidity and rehydration, kind of by opening up the joint, kind of allowing the synovial fluids to kind of disperse more throughout the joint. And the traction can also help reduce nerve root impingement that is kind of created by the disc protrusions that occur. So pain, little fun fact, pain is reduced with the forces of 30% and 60% of the body weight. Next slide. All right, and then here are a list of some contraindications that come with lumbar traction. First one is vertebral fractures and spinal segments. Unless it is physician approved, would really recommend not using lumbar traction. There's also hypermobility of vertebral segments, the unknown origins of pain and discomfort, herniated discs, arthritis, rheumatoid, and osteo, and any subluxations and dislocations that are within the lumbar spine, as these can all cause weakening of the soft tissue structures. So next, indications here listed as well. These include nerve root compression, radicular pain, herniated and protruding disc, degenerative disc disease, lumbar muscle spasms, and facet joint pathologies. Lastly, so for precautions, we want to ensure that the patient is being monitored closely during treatment. And we want to stop if there are any increased symptoms of pain or discomfort that they are experiencing throughout the treatment. We want to be wary of potential ligamentous damages. So we'll start the traction low and kind of progress as needed based on how the patient is feeling. And lastly, we use sustained or continuous traction if lumbar motion is contraindicated otherwise. So.
All right, so going back again to just talking about some of the recent evidence, recent research that's been coming out lately. Again, it's pretty similar to cervical traction. When it comes to lumbar traction, it's going to be mainly used for short-term relief of symptoms. There's a lot more short-term implications for things like herniated discs, just because you're reducing those compressive forces you think about that donut with the jelly, more pressure you have, the more jelly is going to come out. So if you take out some of that compressive pressure, that should help to alleviate symptoms. It is better than only conventional physical therapy, but when you combine lumbar traction with physical therapy, that's usually when you're going to get better results. Um, However, again, just like with cervical traction, there are still a lot of inconsistencies within the research. A lot of that also comes with how we position the patient. There hasn't really been anything consistent as to whether or not placing the patient in a supine position or a prone position is better or worse than the other. Also, taking a look back into the research, a lot of the case sizes are still pretty small. Everyone's using different parameters, and again, the results are just kind of different especially patient to patient. So at the end of the day, there's not really any conclusive evidence for the general practice of using traction. There is some evidence for using lumbar traction in regards to lower back pain, but just like with anything else that we kind of talked about so far, it's still pretty inconsistent. And the studies will typically talk about the positive short-term effects as more of a possibility rather than certainty. So, basically speaking, using traction for lower back pain could possibly help with symptoms, but again, it ranges from person to person. So at the end of the day, when we're talking about traction, both cervical or lumbar, if we're thinking about what we want to do clinically and what's kind of like following evidence-based practice and things like that, there isn't a lot of research, and there isn't a lot of evidence to suggest that we should be doing this, especially if we're thinking about long-term issues. But it is possible that traction can help with some short-term pain relief, but at the end of the day, not the research just isn't there to really suggest that this is what we should be doing. It could possibly help in regards to it being combined with things like physical therapy or other therapeutic modalities, but at least on its own, traction is not really going to be the greatest thing that we should be focused on in turn when it comes to helping our patients with any cervical or any lumbar pathologies. These are just the references just to show that we didn't steal anything from anyone. And that should be it.